Hello, good morning, good afternoon, good evening. Um, it is an honor and a pleasure today to start the series of webinars in the space of health tech and technology, which has been changing uh, business and healthcare, the industry of healthcare from drastically in the last couple of years. We all have gone through a major shift during the COVID times, and COVID has made us understand the importance of healthcare as such. But the way healthcare delivery has shifted, specifically in the last 10 years, has been drastic. A lot of it has been at the backstage, changing slowly and steadily to give you better consumer experience, better health outcomes, and better delivery of care, both from the provider network as well as from the network of um, tech and finance innovation, bringing that forward for you. And for that particular reason, we have set up this series of webinars to employ as well as bring to the foresight these innovations that have made our lives much easier in the field of healthcare. Today we have with us on that note Mr. Indra Kumar Jha. Indra, apart from being exceptional nautical engineer, he is also a master's in entrepreneurship from IIM Rohtak. Last couple of years, I believe he has spent almost entirety of his time in improving the field of healthcare the same way he has worked to par excellence in the field of nautical engineering. With Alpha Group and their flagship product ZiffyTech, they have been able to penetrate rural healthcare to a um, certain degree of tech innovation. They have been able to set up kiosk centers to bring in structured medical advice to the Indian market, where a lot of healthcare seeking behavior goes directly from a pharmacy's perspective. And that has improved health outcomes to a great degree. Thank you so much, Indra, for joining us. It's a pleasure to have you. So today, let us discuss a little bit about the challenges you are from Bihar, you have operated in tier 6, tier 7 cities, and areas which we might not traditionally call as city infrastructure. And you have been able to effectively bring in health tech to make large scale differences in these areas. So thank you for your work, but we would love to understand the kind of challenges that you have faced when you started building this network of innovation.
All right. So challenges are basically, in all three stages. Number one, when you build the product, when you identify the problem has to be a real problem and hard pressing problem, A. B, then, developing a technology or the solution which can really hard hit the pain point, which is, the pain point which we have hooked upon, building a team, then launching the product and making the behavioral switch happening onto the ground. Because when we are coming up with a new approach, with a new technology, with a disruptive force methodology to solve that problem, the acceptance becomes a challenge. So unless the consumer test your product, unless the consumer experience your product, so you have to bring the consumer from their comfort zone, the conventionally what is the less efficient and the less effective method what they're adopting to solve their problem. From that comfort zone, we have to bring him back and introduce your product. So that behavioral switch is one of the greatest challenge which you have experienced so far in terms of executions happens.
And that's really interesting when you put it that way, because India, the market that you operate out of, is one of the largest, rather the largest now, if the numbers are to believe, across the world. And the entire region of Southeast Asia has networks of similar problems mirroring each other through traditional network of healthcare delivery. And innovation like yours are slowly and steadily shifting the behavior of the patient for structured healthcare seeking. So, can we dig a little bit more about the problems that you face being a tech innovation in the rural care space? Because I'm sure that you have stories to regale us with, which might have changed, which might have made large scale differences, but were daunting challenges to begin with.
Yeah. So let's give you the practical example that, when let's say the patient is, trying to take their, let's say he is fallen sick in a remote area whatsoever, there is an access to the healthcare is the big problem. To even access to the proper MBBS healthcare professional, he has to travel more than 5 to 10 kilometers. For a specialist, 30 to 40 kilometers, and any kind of a big hospitals where the kind of a surgery is required, maybe 100 kilometers. So that kind of ecosystem, what we have, the Asia at large and the India specifically, into the when 72% population lies into the rural, ecosystem. So they has been conventionally believing that when they go to the doctor, uses the stethoscope, they hear in person, they are, the cardiopulmonary sound, they check the pulse, etc., and the physical connects, then they feel that this is a consulting. But yes, what actually is happening when the patient is reaching out to the doctor, you are facilitating your body to in front of him so that he can take those analytics, health analytics, like your blood pressure, your blood oxygen level, or random blood sugar, or even he can hear your cardiopulmonary sound and he can talk with you. So doctor is a professional. He's not a kind of, the antaryami. He's not a god that he's just being in front of each other. He can solve your problem. So the idea behind is that with a similar scenario, our problem is trying to solve that physically patient may be at his doorstep or maybe the nearest pharmacy shop or our e-clinic of the ZiffyHealth, where his all the vital statistics on which basis the doctors makes the judgment and the clinical decision making happens. Those data we are through the IoT enabled ecosystem, we are able to bring into the doctor, and he can live environment, he can even hear the cardiopulmonary sound, direct heart and lung sound. So we are trying to leave no gap behind. So we understand being a technology driven and being, this attacking to the pain point directly. But as far as the consumer is concerned, being physically presence, they have been conventionally doing it. So what we are doing there, we have to create a lot of awareness. And that is one of the key challenge. And we do onto the ground. The awareness is our solution through which, various methodology we apply, and we encourage the people that you experience this. When they experience, then they love it, our solution.
So basically, just the fact that to get the patients to your kiosk to experience it for the first time is one of the biggest challenges,
Yes, in
right?
terms of the customer journey, the moment they experience, that how effectively, with the help of our IoT enabled solution, the doctor is able to do a right analysis of the diagnosis of the ailment, and then medication is given. There is also a lot more smartness in terms of salt composition, etc. And the end result is experience that recovery happens, quick recovery happens, and people are satisfied. Then they become very loyal to our platform. So bringing them from their doorstep to the kiosk is the biggest practical sense.
That's really interesting. The thing is that I think that is the outreach and the education of the patients is one of the largest challenges that we have faced in establishing innovative solutions in the healthcare value chain across the years also, be it immunization, be it different models of healthcare delivery, or even screening forward solutions. All of them have required a huge inertia build that we have to break up and go and get the patients to either work out or adopt the technology even at their homes. Extending that, what are your thoughts? As in, which technologies do you think are still necessary to improve care, especially in the rural spaces? You guys have been bringing in some part of the solution into the value chain. What does still remain to be solved? What are your thoughts on that?
Okay. So our IoT, there is a plethora of the products in terms of the IoT devices, which can really bring the complete, with 100%, 100.00%, all the health analytics to the doctor remotely wherever they are. So primarily we have a plan to go step by step. So first we are trying to solve the primary and secondary healthcare. So that is the 6 vital is very, very necessary, that blood pressure, temperature, blood oxygen level, random blood sugar, ECG, heart rate and cardiopulmonary sound to analyze. That's the step 1 what we have done. Then what is yet to be remain, which can bridge in the online and offline consultation gap to almost virtually zero. That's a couple of other things which are in the pipeline, that you needed the the IoT devices which can take the macroscopic picture of your inner side of your eardrums or ear. Also the in the examination, the inner side of the mouth, that your tongues examination, etc., also plays a critical role. Sometimes very close view of your retina and eyes, that gives a lot of judgment to the doctors. So these kind of devices is required, and that we already in progress to do the IoT integration. So these are, I guess, necessary. Moving ahead further, that if let's say the doctor should not make a judgment just based on the current momentary value of your vitals or any kind of a dynamics, let's say your LDL, SDL, cholesterol, or your blood pressure or ECG, etc. Rather, he should have a seamless historic trend. And since the patient has been majorly onto the paper-based solution, so OCR is another key, that with the help of the OCR technology, so this pictorial format of this previous medication history and their diagnostic report, etc., can be uploaded, can be converted into HL7, and then through the FHIR framework, the doctor can access at that consulting time in real time. So that will give you deeper insight. And once the doctor gets the deeper insight in terms of deciding the ailment, then he can give effective medications. Those are a couple of things which is required, and we are moving towards that as well as a team, our technology team. OCR also around 80 to 90% accuracy. It is working with us, and we are upgrading it. And the next is the CDSS system, the clinical decision support making system. As you know that the 80% doctors are living into the urban ecosystem, whereas the 72% population into the rural ecosystem. So there is a huge disparity. And in terms of doctor and patient number, whereas the WHO recommendation is 1 into 1,000, we are 1 is to 11,000, 11 times shorter if you're talking about the India perspective. And if you talk about certain states like Bihar, Uttar Pradesh, Bihar has 29,732 patients over one doctor. So that's a huge load. So this problem, we cannot open the overnight medical colleges and institutions and produce the doctors to fill those gaps. Rather, the immediate solution lies that how we can cut down the per patient engagement time without compromising to the quality of the treatment. And that is possible when we empower the doctor with various kind of AI-driven tools, the ML-driven tools. So the CDSS is one of the support system. And, I guess these are the couple of things which, I believe is very necessary at this moment, and it's very relevant to solve the India's burning issues of the healthcare.
So, Ziffy has been working not only in Bihar but Uttarakhand, in India, some of the more rural areas where traditional healthcare has not been able to effectively penetrate rural Maharashtra as well. And I would really like to understand the scope of Ziffy's work as well, just for the ease for our audience, to understand exactly what problem are you trying to solve. What is the behavioral concern that we have with the current health seeking behavior for patients? And how the presence of Ziffy Health in that area is solving those particular problems.
Yeah. So as you ask about the problem and the solution. So the problem is basically what we are trying to do to bridging the the disparity between supply and demand of the healthcare professionals, especially between rural and urban ecosystem. I think it will be a bit repetition that as I said that 80% doctors into the rural into the urban, they lives into urban ecosystem, but we have a 72% population into rural. So they have only access to 20% doctors, and that leads to inadequate access to the healthcare, whereby subsequently then they fall into the prey of trap of the quacks and etc., which are not well qualified, and they further complicate the issues. So that leads into the wastage of the money, because the longer it goes.
No, Indra, it would be great to explain what quacks are to our international audience. I don't believe that is a term
Yeah.
very well known by
Yeah,
everyone,
yeah.
apart from.
So yeah, in India there is a kind of a scenario, and I think whatever scenario is there, that's an outcome of the ecosystem. So as I have been mentioning that there is a huge scarcity of the doctor. We have certain states, except where you have 29,000 plus, the population over one doctor. So that leads to reaching out to the people who are not well qualified and certified by the governing authority of that law of the land and by that country. And they are practicing and suggesting the people, on the basis of half little knowledge. So they
Mhm.
are typically being called here quack, and they are treating the people, which is very very dangerous, because sometimes they don't have the adequate knowledge that what is the ailment, what medicine has to be given. It leads to sometimes reactions of the medicines. And the problem get added upon when you talk about the the pharmacy center. People goes to the pharmacy center, they say that I'm having a pain into my stomach, I have a pain into the chest, and they give the medicine, which is as per legal framework we not allowed, but in a practice it happens. Why it happens? Because that such circumstances and situations are like that the people are not having access to the doctors. That leads to the wrong diagnosis, wrong medication, and leads to sometimes fatal scenario like death. Kind of a reaction of the medicine happens and all. So that's very very worst scenario. To solve this problem, we are collaborating with the majorly with the pharmacy centers. And since in India you will find it, the penetration of pharmacy centers is very far and wide, unlike the doctors and etc. So as you can see, summarize it, the healthcare is like a triangle. So you have a three side to it, majorly the doctor, diagnostic, and pharmacy. So wherever there is a one side, let's say the pharmacy is one side, so we connect with the help of our IoT enabled kiosk, the doctor and diagnostic. And so where the footfall happens, the curative, let's say talk about curative healthcare management. So people are going when they have a certain issue to the pharmacy center for the medicine. Then our pharmacy partner, they are the franchisee to the ZiffyHealth IoT enabled kiosk. So they insist and suggest them that why you are doing self-medication, it may cure the symptoms, but not the ailment. So why not you can avail the doctor right away, and where there's a gap, zero gap between online and offline consultation with the help of the IoT enabled ZiffyHealth kiosk. So the people come, they take consulting, that's effective treatment happens, and that we are able to solve this problem. So your second part of the question, as you said, that in a true sense, we believe that the Jiffy Health is endeavoring to override to geoterrain barrier and make the healthcare accessible across the geographies. So that's why you can see that we started around 1 year ago from the Pune in the Maharashtra, which is the west coast of the India, and we have reached up to even the northeast section of the India, which is around more than 2,000 kilometers, approximately the Assam and Nagaland, up to those area also. We have even expanded to Jammu Kashmir, and successfully we are able to do so because technology is the real tool which gives the advantage and leveraging us to make the healthcare accessible wherever and whenever it is required.
You are correct, Indra. I think that's a very necessary solution. I would like to add to what you were saying earlier as well. So, one of the problems that I, as a healthcare practitioner in the field, have faced is that not only are there, unauthorized people prescribing medication in the rural spaces, they basically form the entire healthcare infrastructure of the region. So, and it's not, of course, fatality, mortality are some of the worst case scenarios, but the current COVID crisis ended up showing us that excessive use of steroids or excessive use of antibiotics has eroded overall immune responses of people to a to such a degree that now most of this medicine are not very useful. Steroid has reduced immune response to a certain to such a degree that most of the population is now highly susceptible, and the use of steroid is largely to get early responses or feel good factors, and hence more and more people coming in. So this has been termed as a secondary pandemic, where a lot of such unauthorized and sometimes even authorized professionals have been prescribing medication not according to the clinical plan or cycle, but according to what the patient might feel better with immediately instead of treating the problem. not even treating, but just elevating some of the symptoms and making sure that they solidify or capture the marketplace of healthcare delivery in those areas. And similarly, there is a whole regulatory crisis also, where even though we have very strict guidelines about OTC and non OTC drugs, none of that is really employed or enforced in the rural healthcare space, which is why solutions like yours are very, very important, because we know that most of the antibiotics in India are non-prescription, as are prescription-based medication. My apologies, but still, most of the pharmacy is distributed like opens, and they really don't check for either proper valid prescription or even association to a doctor for such matters, and that overall reduces population scale healthcare outcomes. So I think that is something that's very, very important, and what you're doing is a step in the right direction, to say the least. So I also wanted to understand your views, because I did mention a bit about the regulatory structures. Indian government has been one of the more active governments in trying to adopt tech-based solutions, be it solutions like eSanjeevani, which is another government-based free health tech solution, or now Abha number and several other things which are access to health records, the same way that you mentioned historical health records being extremely necessary for a larger picture of health for individuals. Where do you see these solutions coming into place and helping private sector entities like yours?
Yeah. Yes, Dr. Sabine, rightly you said that recently the Indian government has taken a lot of initiative in terms of streamlining the comprehensive and seamless platform building. Like all the records has to be in HL7. Even let me tell you that in the India government's Gazette of 2018 itself, they gave a directive to the platform. All the healthcare players should move on the electronic health records to HL7. But unfortunately, it takes a lot of lag time is there. The regulatory bodies, what they make, and onto the ground, what happens. So here probably we have to, all of us has to come out of their own comfort zone and just should not work for their own benefit, because I guess healthcare is a larger social the cause driven matter. So here it's the players should not only make such models which will keep the patient captive. Rather, we should work towards whether we can help the democratizing the healthcare ecosystem, and where the FHIR framework, which recently, this National Digital Health Mission of India is giving a lot of stress, and ABHA ID, whereby all your records will be, the combined together, and it will be accessible. Its data has to be interoperable. So these kind of initiative is really, really highly appreciated. But on the same note, as you know that we have the 1.45 billion population. It's a huge. The world's 1/3 population lies into the India subcontinent. Challenges are very big. So I guess it is not only the government probably who can solve the problem. There should be a lot of PPP models should emerge, and in my opinion, government should respect, and they should embrace that PPP model, whereby the private player can collaborate and leverage the even government infrastructure to bring the fast track results. Like in India, the PHCs are, I'm sorry, I'm not criticizing, but I'm putting up some hard facts that the PHCs are in a very, very, the bad scenario. There is only the, let's say that, the paramedical comes and etc. And people are not getting really access. Whereby if, let's say, in the each PHC, if we can roll out the, this IoT enabled health kiosk in that scenario, I guess, this, since the live vitals and live electronic health record is accessible to the doctors into the referral hospital or city hospitals. So the expertise of the big, cities doctors can be seamlessly, bring down to the panchayat level, block level, to the village level. So combining, the government has a huge infrastructure, but yes, to increase and enhance the effectiveness, such kind of a collaboration will be a great thing to do together. and together we can solve the India and we can make the healthy India, wealthy India. And not only in terms of the India perspective, wherever such kind of a scenario exists, probably the PPP model should be fair enough. As far as the e-Sanjeevani is concerned, it's a great initiative, but there is certain lacuna to it. It's again the kind of a pure, simple, conventional consulting, whereby doctor and patient is coming onto the video, and there is limitations to the doctor to access your exact cause and the nature of the ailment, because only doctor has to believe on the basis of what the patient is telling. So there is a lacking of the live vitals as well as the previous electronic health record, trend analytics, etc. So its effectiveness is pretty less. So this e-Sanjeevani, if let's say you collaborate with a player like ZiffyHealth, so there'll be a huge opportunity to upgrade the ecosystem, and together we can make a huge impact, which is our objective of the entire the nation.
One more thing I wanted to actually look at is, you have spoken quite passionately about how connecting vitals and certain vital information does help in diagnosis remotely. And for many, many cases, I agree with your tenet. But being a clinical doctor myself, I still, even I have my doubts about the limitations, or rather, there has to be certain limitations of an in person diagnosis and investigation. And more than investigation, examination processes, right? The cardiac, the renal, the neural reflex examinations versus the information that can be received from POC devices, that is point of care devices. So where do you see that limitation coming into play, and how many patients are covered through this IoT network and the virtual consultation, and how many really go to referral networks? And if so, what are the ways and what are the technologies that is being worked upon right now to eliminate some of those limitations?
Okay, so yeah, before going to the limitation, let me tell you to solve the one kind of a limitation what we have came out, that let's say the patient is first of all had a certain ailment, and he's consulting to the general physician. In the primary healthcare center, or the kind of in front of our kiosk, there is only paramedical who helps them to fetch all the vitals data and their electronic health record, etc. Then the general physician is trying to treat him, but he can see a cardiac complexity. So in runtime, normally conventionally what happens, then doctor refer onto the prescription to the cardiologist, and then he has to go and search the cardiologist, and it takes 1 day, 2 days, and then he go there, a lot of wastage of time and etc. So to solve this problem, we have put up the facility whereby the multi-doctor can have access onto the same platform into the same time. So he can, in a runtime, he can take the cardiologist there, and the general physician, patient, and the cardiologist, all three can have access to seamlessly onto the electronic health record as well. They can have a common conversation. Further, if they can see there's a diabetologist requirement, so he can take in a runtime diabetologist itself, and there will be combined discussion, and then the final medication is given. So if the doctor is giving, let's say the primary medication has been given, and he understands that there has to be a, let's say that deeper understanding of the ailment, lipid profile or LDL, SDL, onto cholesterol, other stuff. So we are trying to solve this problem through the spoke and hub model, in which we have a central e-clinic, in which we have a digital diagnostic center, and onto the spoke, the north, south, east, west, approximately 5-kilometer radius, we put up the 4 peripheral e-clinic. So idea behind is that in a 7.5-kilometer radius, nobody should be required to travel more than 2.5 kilometers to access such kiosk. And this 7.5 kilometer means 150 square kilometer roughly, which is aligned to 3 lakhs to 4 lakhs population. So, that's kind of a ecosystem we are trying to build to solve this problem. But yes, there is a challenge in terms of radiological, issues. So radiological equipments are expensive. So slowly, what is our idea, that we do not put up this, digital diagnostic center into all e-clinic, rather into central e-clinic. Similarly, with the help of our LVD, which is a 7 centimeter by 7 centimeter live vital access device, we are able to give the single lead ECG, which is only for, the limitations are there. But we are incorporating even the 12 leads ECG IoT devices into that, but that adds on to the cost. So we have to see the affordability as well, and we cannot make the each system, unnecessarily capex intensive. So we put these system into the central clinic, which is just the 5 kilometer away from the peripheral clinic. So that's an optimization between the cost, affordability, and the quality. So yes, certain limitations are there, as I said, the radiological, and but we are trying to solve with our the partnership and building a seamless ecosystem over there.
Right. No, makes sense. Coming back to one thing that we mentioned earlier about limitations. So, what are the limitations apart from radiological and image-based investigations? Or what are the limitations that you see right now in terms of POC devices? What are the vitals that are being captured versus what is not being captured? Where is there research going on that we will see in the future coming up, which will be optimizing the use of POC devices much more towards decentralizing healthcare, the way
Mhm.
you said about democratizing healthcare in outside the hospital, making sure that we do not need these megalith structures always to go seek effective healthcare solutions.
Yeah. So yes, of course, the another limitation is that if you need, after all, investigation, etc., if you need to see that needed a surgery, it's needed a, let's say, the kidney transplant, a heart transplant, etc. So of course, then the patient has to be bring into the the nearest hospital. And to solve this problem, what we have done, that we have partnered with the the ambulance aggregator. So in our health kiosk itself, if you press the SOS button, so then the nearby ambulances get those alerts and they come over, and then when they pick up the casualty, they can see onto their their ambulance app that which hospital has a live bed status, whether it's a cardiac bed, whether it's an ortho bed, etc., so that the right type of patient should reach to the right hospital. And the moment the hospital is clicked onto that ambulance driver's app, then in their emergency ward, the flicker and the appointment comes into the play into their queue management system into emergency ward, and the flicker and the sound buzzer sounds the name of the person, XXX, nature of this emergency, let's say cardiac arrest, ETA, estimated time of arrival 12-30 hours. And then even the doctor is, let's say, into the emergency round, he's not into front of the emergency panel, so he can have even mobile in his pocket and he can hear those buzzer and can acknowledge those. So he understands the person so and so is coming, he can track there. Going beyond, we don't have always the the ICU enabled and ICU equipped ambulances. There is a majority is the plain simple ambulances which just serve the purpose of carrying the patient from the casualty space to the hospital. So we are empowering with the simple those ambulances with the simple IoT devices. With the help of that, if the patient is coming from the far, it is taking time or it is stuck into the traffic jam. So in this scenario, the situation may get worsened. So with the help of these IoT devices, doctor into emergency ward of that hospital is able to get the live their blood pressure chart, their ECG, on-card heart sound, etc., and can give them a lifesaver advice. So that helps the patient, to survive and till further to not deteriorate the further scenario till the time they reach out to the hospital. And prior reaching to the hospital, doctor knows their complete electronic health record by seeing them there, what kind of that they're diabetic or there's hypertension or there any kind of a surgery that happens. So there is a zero loss of time. As soon as the patient comes, the treatment starts, and the likelihood of the patient's survival get upgraded and enhanced. So yes, as I said, limitations are there, but we are working slowly that each limitations can be plugged in with the help of right process, right technology, and right approach.
I agree with you. One of the things that I feel as well is there's a lot of research going on in the POC networks and in the POC devices. For example, today we do not have a clinically valid POC device to understand liver function, kidney function at a POC level. Most of it is basic vitals that are then interpreted.
Mhm.
So I think now we are getting more and more devices which are lesser invasive, which are more accurate, which are clinical gold standard around, hormonal testing, which is extremely costly in a lab right now. or towards liver function test or kidney function test, which is not really viable right now from a device perspective, or even diagnostic tests like or rather HbA1c, which is not a diabetic, uh, which is a classic diagnosis test for diabetes right now. So a lot of these now are slowly becoming possible for decentralized care, as you rightly mentioned. One of the things that I feel personally where there is a huge gap is the intervention space. So a lot of devices and networks are generally we use as point of care are diagnostic in nature, but they do not have direct intervention capabilities. And possibly with further research, the way we see a lot of device entities researching and growing in this space, we might be able to, in the near future, or maybe sooner than we expect, be able to intervene to certain health crisis systems through device forward solutions, even before reaching to a hospital or without the need of reaching to a hospital in the first place. So I think that there are some very interesting ways we can go from here towards bettering healthcare systems in the rural space, creating access, reducing cost, and more essentially improving accuracy of care. So thank you so much, Indra. You are doing a great job and would love to see where you take it from here. Um, Thank you for joining us for this podcast.
Thank you, Sabine. Thank you, all the audience. Have a great day.
Thank you so much.
Thank you. Bye.
Thank you.